Dr. Ritesh Roy is an Associate Clinical Director and HOD at Care Hospitals in Bhubaneswar in Odisha. He is the innovator of many different blocks and an executive committee member of AORA India and has received the Lifetime Achievement Award in 2019. His special interests include USG guided RA and difficult airway management.
Thank you very much. At the outset, I congratulate Rushali ma'am and team for a wonderful conference and hope so it goes on very smoothly. And congratulations and thanks to all the delegates. Post-lunch, full house. This is Aura. Time, punctuality and full house. And so it's a clap to each one of you. So I will be speaking on PNS guided axillary block. So obviously brachial plexus, you all know I'm not going to go into detail of it. And what is the axillary approach? If we block the terminal branches, that is the musculocutaneous, the median, the ulnar and the radial nerve individually at the level of axilla. And what are the indications? Usually below elbow, that is forearm and hand surgery, outpatient clinic, and in chronic pain, people have used the axillary approach in a chronic pain. So, as Sir told, Bala Sir had discussed, for any surgery, you should know your dermatome, your myotome and osteotome. If you are missing any one of it, your block will fail. So, forearm, the dermatomes are the musculocutaneous, the radial nerve and medial cutaneous nerve of forearm. Myotome is by radial nerve, ulnar nerve and median nerve, and osteotome is by radial nerve and median nerve. And axillary brachial plexus block is enough to cover all the three aspects. For hand surgery, it is all ulnar, radial and medial, except the osteotome, which is only by the radial and the medial nerve. And if you give an axillary brachial plexus block, your each and everything is covered. That is the dermatome, the osteotome and myotome. What is the functional anatomy? The main thing is the axillary artery. Usually all the nerves, they maintain a predictable relationship, orientation relative to the axillary artery in almost 65% of the patients. I am not going to go into detail because Sri Prakash has already covered this slide. Usually in 65% you have the predictable relationship of the medial nerve, the ulnar nerve, radial nerve and the musculocutaneous nerve. Usually if you see at the cross section, the axillary artery, the relationship is divided into the superficial quadrant and the deep quadrant. The median nerve lies in the upper superficial quadrant. The musculocutaneous nerve, it lies in the upper deep quadrant. So the median nerve and musculocutaneous nerve can be accessed by the same puncture site above the artery. For a median nerve, you go at a shallow angle of 30 degree above the artery and same needle you can redirect 45 degree towards the patient head and you can catch the musculocutaneous nerve. The radial nerve and the ulnar nerve, they lie below the artery. The ulnar nerve lies in the lower superficial quadrant. The radial nerve lies in the upper deep quadrant. With a single needle, you can approach both the ulnar nerve and the radial nerve below at around 30 degree below the artery and at 45 degree posterior to the artery. If you redirect the same needle by the same puncture site, you can catch hold of the radial nerve. So what are the block procedures? You have to follow all the block procedures. We use a 50 mm insulated needle. If you have got a PSI monitoring device, use it, that will be better. And this is the initial PNS setting of 1 to 1.5, frequency of 1 to 2 hertz or sensi, pulse duration of 0.1 millisecond. The acceptable motor response current is 0.4 to 0.5. Always reduce your current to 0.2 to prevent intraneural injection. And what are the volumes? If you want to go for a surgical anesthesia, you use around 0.5% ropin or 0.5% bupivacaine. If you want only for analgesia, reduce to 0.2% ropivacaine or 0.25% bupivacaine. But obviously, watch for last. Calculate your dose. These are always calculate your dose, seeing the weight of the patient. The position, patient lies supine, arm is abducted at 90 degree, elbow flexed at 90 degree, but don't abduct the shoulder more than 90 degree as the axillary artery palpation becomes difficult and nerve comes slightly superficial, so you might damage injure the nerve while doing your needling. So what are the landmarks and needle insertion site? Mark the highest point of axilla, palpate the pec major muscle, palpate the triceps, mark it, palpate the biceps and mark it, palpate the coracobrachialis muscle and mark it. Just below the coracobrachialis muscle, you can feel the axillary artery pulsation. Mark the axillary artery. Put two needle insertion sites, one above the artery for median and musculocutaneous nerve, one below the artery for radial and ulnar nerve. So this is the block technique. For median nerve, the needle goes in a superficial above the artery at 30-degree angle, superficial at 30-degree angle. You start seeing the median nerve response. So what are the median nerve response? You will start seeing the flexion of the first three fingers or wrist flexion and pronation. Reduce your current to 0.4 to 0.5. If the response persists, inject around 5 to 7 ml of local anesthetic. For musculocutaneous nerve, same redirect, the same needle, redirect to the patient head at around 45-degree angle. You can start seeing the elbow flexion. Reduce your current to 0.4 to 0.5. If it persists at 0.4 to 0.5, inject around 5 to 7 ml of drug for the musculocutaneous nerve. For ulnar nerve, the needle is below the artery, superficial at an angle of around 30-degree, shallow angle of around 30-degree. You will start seeing the ulnar nerve response. So what is the ulnar nerve response? You will start seeing the flexion of the last two fingers, the ulnar deviation of hand and thumb adduction. Reduce your current to 0.2 to see whether it persists. Increase your current to 0.4. If it persists at 0.4, inject around 5 to 7 ml of drug and your ulnar nerve is blocked. For radial nerve, same needle, just redirect the same needle to posterior to the artery at around 45-degree angle. You will start seeing the triceps muscle contraction. Don't accept it because it is a muscular branch which you are stimulating. Don't accept that response. Don't accept this response. This is the triceps contraction. Don't accept that response. Your block will fail. Readjust your needle. You will start seeing finger and wrist extension. Reduce your current to 0.4 to 0.5. If it persists at 0.4 to 0.5, inject around 5 to 7 ml of local anesthetic. So what are the clinical pearls? Triple injection axillary block, that is radial, medial and musculocutaneous nerve is most efficient technique. Separate ulnar injection is not required. And this has been shown in a Cochrane-based trial that multiple injection technique, that is a 3-nerve, is required for a good block. What are the clinical pearls? Sometimes the axillary artery palpation might prove challenging in obese patient. So the first motor response will guide you where your needle is. If you start getting the musculocutaneous response, it means you are outside, above the artery. You can readjust your needle. If you are getting a median nerve response, it means you are above the artery. So the subsequent needling can be guided by the first motor response. The more difficult differentiation is between the median and the ulnar nerve because both result in wrist and finger flexion. In this scenario, if you are having a finger flexion plus forearm pronation, that is a median nerve. Also, the palpation of the flexor tendons at wrist can help you. The median nerve stimulation will cause movement of the palmaris longus and flexor carpi radius tendon, and ulnar nerve stimulation causes movement of the flexor carpi ulnaris tendon. What are the advantage? As Sri Prakash has already told why axillary approach we prefer. What are the troubleshootings? If you have arterial blood, venous blood in the tubing, readjust your needle. If you have stimulation of the biceps muscle, it means you are quite superior. So come down. If you are having stimulation of the triceps muscle, it means you are quite inferior. Bring your needle insertion site above. And if you are having paresthesia, it means you are touching the nerve. Readjust your needle. So what are the possible complications? You can have vascular puncture, you can have hematoma, you can have LA toxicity, and you can have nerve injury. So take care of those things. These are the contraindications. There are very minimum in axillary, but if the patient is sensitive to local anesthetic, if you have got a local infection or the patient is on anticoagulant, it's a relative contraindication because you can always apply pressure and do it. Thank you very much for your patient lens. Thank you.